Greetings. In this lecture we're going to discuss functional outcome measures, and we're going to focus on the questionnaires that are most relevant for patients with shoulder disorders. I think it's the perfect lecture to have pre-recorded because obviously there's no lab portion to this. There are many outcome measures to choose from. This is just a partial list of some of the more common ones. There are so many outcome measures to choose from. Kind of leaves us wondering, what should we do? Okay, Napoleon, sorry about that. Pick whichever one works best for you. For simplicity within this lecture, I chose to focus on two different outcome measures. One is the DASH, or Disabilities of the Arm, Shoulder, and Hand Scale, and the other one is the Patient-Specific Functional Scale. Both of these measures are more specific to the upper extremity than some measures such as the SF-36 for quality of life, but they're also not too specific to one particular pathology or population, like a rotator cuff quality of life measure. When they become too specific, they limit their use to a variety of shoulder patients, and sometimes you don't even know when you first have that evaluation which population you should apply it to if it's very specific. The main things we will discuss in this lecture are related to the rationale for why we would choose to do an outcome measure to begin with, also including some G-code and evaluation complexity coding considerations, the composition of the tool and what's in it, validity by population, responsiveness or sensitivity to change, or how much change we would need to see for a patient to be able to notice a significant improvement, and reliability. So further discussing why bother doing these outcome measures, well, we want to document improvement. So further discussing why bother doing these outcome measures, well, we want to document improvement. We can use them to guide our evaluation when we incorporate some information from the history to help classify the patient. If we ever want to go back and do a retrospective study or a case report, this information can be very helpful. Some insurance companies require it. It helps with G-code selection and can assist with justifying evaluation code complexity. Regarding G-code selection, there are a couple G-codes that are very relevant to patients with shoulder problems. The code discussing carrying, moving, and handling of objects is probably the most relevant, and it emphasizes activities from the DASH such as pushing open a door, putting an object on a shelf or reaching above your head, carrying objects, using a knife to cut food. You could also use the self-care G-code, and from the DASH it gives you a couple of functional activities related to self-care that a patient could rate. Certainly you could use the patient-specific functional scale for either of those, and very specific to what the patient tells you their limitations are. And you may use the categorization within the DASH or the patient-specific functional scale to help support the reason you choose a certain percentage limited for each activity. These outcome measures can be used to help guide evaluation code complexity, a requirement that began in 2017. Clinicians are required to indicate how many elements they are addressing in their examination and treatment plan. Within the examination of the body systems, some of the elements include body structures and functions, activity limitations, and/or participation restrictions. The activity limitations would include things that relate to having difficulty executing a task, such as hanging up laundry for shoulder flexion, using the right upper extremity to assist with washing hair, again with shoulder flexion, using the right upper extremity to open a door, where you would reach forward and pull, externally rotate the shoulder to put a coat on or remove a coat, which will require a number of movements, one of which is shoulder external rotation. So you can tie some of these activity limitations to some of the impairments the patient has in your documentation. You can also use them to describe participation restrictions, such as limited ability to participate in a life situation, such as being able to play softball or being able to work as an automotive technician. So these outcome measures will be able to be coordinated with the selection of the evaluation code complexity and could be helpful to stratify the evaluation code. Here's a copy of the DASH. As you can see, it's a longer test and it has 3 pages, although you could shorten it to the work module or the sports or performing arts modules, which have only 4 questions each. It will take the patient several minutes to complete the full version and a couple minutes to score it. Within the DASH, there are 30 questions. 5 are related to symptoms and 25 related to functional tasks. The minimal clinically important difference is 10 points. The 2 optional modules I discussed in the previous slide relate to either work or ability to participate in sports, and those might be more helpful than the full DASH in some patients who can do most daily activities really well but are unable to do a highly demanding employment position and requirements and unable to participate in a sport. Unfortunately, there is no known minimal clinically important difference for those optional modules. If you do want to simplify the scoring for the full DASH, you can complete it online. You can have the patient do it and you can then print and score for free, or there is an app for that if you're so inclined. Regarding the patient-specific functional scale, it enables us to quantify an activity limitation that the patient has and can be, as its name suggests, very specific to that patient. The verbiage that you are supposed to use in administering the test is, are there any activities that you are unable to do or are having difficulty doing because of your blank problem? So in this case we'd say shoulder problem. You can then show the scale to the patient. They can pick a number. You indicate 0 is being unable to perform the activity, and a 10 means the patient's able to perform the activity at the same level that they were able to prior to their injury or problem. You can select up to 5 activities. The time to complete the test and score it is less than 5 minutes. Once the patient has given ratings on the patient-specific functional scale, we can then take the ratings and generate a composite score, where you take the sum of all the ratings or activity scores and divide them by the number of activities they rated. The minimal detectable change for the average score using 3 to 5 criteria would be 2 points. And when this has been validated in upper extremity musculoskeletal problems, meaningful change was even less than that. The minimal detectable change for a single activity score is 3 points, so sometimes a patient can do everything they want to do except for one activity. Well, you could still take that activity, rate it within the patient-specific functional scale, just need to see a larger change in the score for it to be valid. Both the DASH and patient-specific functional scale have been validated in patients with shoulder pain. Both of these scales also have high test-retest reliability. In summary, when choosing an outcome measure, it's helpful to look at what population we intend to apply it to, consider how useful the test is for clinical and reimbursement purposes, to ask the question, is the test reliable enough to be able to apply it? And is it responsive to change? And also, does the test have any ceiling and floor effects where the test may not be as useful for patients who are really high functioning at the beginning of rehab, or really low functioning and who may not be able to achieve as high of a level of function as the test is able to discriminate. Thank you for your time. I hope this was useful, and I certainly encourage you to apply some of these tests to the clinical setting if you aren't already. Thank you. Here's a list of some of the references and a continuation of the references. Thank you for your time.